Hello and welcome to Community Matters, a podcast from the Canadian Association of Community Health Centres. I'm your host, Hilary LeBlanc. On this episode of Community Matters, I'm speaking with Shobha Sharma, the Executive Director at Central Interior Native Health Society, a community health centre in Prince George, BC. Central Interior Native Health Society recognizes the unique healthcare needs of Indigenous people and people who live on or close to the street. Their goal is to provide culturally safe and proactive healthcare that promotes physical, mental, emotional, and spiritual harmony of Indigenous peoples in Prince George. How are you doing today?
Great. Thank you so much for having me, Hilary.
Oh, thank you for coming on. First off, I would love it if you could tell me a bit more about your community health center, some of the main aspects of your organization, the communities you serve, and the services and programs that you provide.
Thank you, Hilary. So Central Interior Native Health came into being in a very unique way. It was identified in the early 90s by Indigenous leaders in the community that there was zero primary healthcare or specialized services that were acknowledging or responding in a meaningful way to the impact of colonization on individuals and communities. And so Central Interior Native Health resides on the unceded and traditional territory of the Lheidli First Nations in the city of Prince George, BC. And Prince George, BC is a northern capital. And so we're serving individuals coming in from various surrounding smaller, remote communities and towns to receive specialized care. And so as these individuals are coming in, it was just identified that individuals that live here and are coming in for services are struggling, and we're struggling from the impact of colonization. And so how could we create a primary healthcare model that could support those individuals? And so on our journey, we've evolved into a community health center that provides an equity-oriented healthcare model. And so our equity-oriented healthcare model really looks at trauma and violence-informed care. It looks at person and family-centered care. It looks at harm reduction, no barrier, and also wraparound services. And so in order to provide that, we've created, and now we have a really strong interdisciplinary team. And so while we have nurses and nurse practitioners and doctors and medical office team members, we also have a really expansive psychosocial team. And so that's social workers, mental health clinicians, wellness counselors, outreach. We have physiotherapy. And in addition to that, we have this extraordinary Indigenous team of elders, knowledge holders, Indigenous outreach support workers, being able to address various needs of our clients. So really looking at the emotional, the mental, the physical, the spiritual. And so our team works in collaboration, and that's every week our team comes together in a meeting so that we can actually look at case management and help to identify where a provider could use the support of a social worker, or the social workers identified chronic pain and connecting a client to the physiotherapist. So it's just this understanding that there's so much interconnectedness in wellness. And so our ability, and I think our strength, is our ability to pivot and to utilize our team in supporting an individual in the care that they're seeking. And because we have this incredible ability to provide care for complex clients, while we started to in hopes of supporting Indigenous clients, and today we serve between 70 to 80% of the population that we serve is self-identified as Indigenous. So the remaining are individuals that are seeking care because they are living on or close to the street, they're precariously housed, they are living with or at risk of HIV, HCV, and sometimes TB, and moms and babes at risk, as well as youth at risk. So we're able to wrap these supports around some of the most vulnerable and complex clients within our community because of our model and because of our approach.
That's wonderful. I think funny, I'm sandwiching this episode, I believe, if everything goes according to plan, with Women's Health and Women's Hands here in Toronto. That's also like a African, Black, Caribbean specialized community health center. And it's the recurring message over these last couple episodes has really been that racialized people, Indigenous individuals, BIPOC people need to have their needs met in the way that like they've grown up and what feels best to them. And it's so important that everyone has specialized, specific care that representation matters, and it's so important to see yourself in the ways that you're being healed or taken care of. And so I'm so thrilled to hear that you guys obviously are doing that as well. Um, Over the past few years, as you mentioned, as we're learning and the world is evolving, we've learned more and more about the horrifying history and realities of residential schools, leading up to an apology recently from Pope Francis regarding the Catholic Church's hand in the creation of these schools. And while this is a critical step on the path of truth and reconciliation, it has at the same time reopened wounds and traumas for Indigenous peoples across the country. How would you say this evolving process has resonated with you, the communities that you serve, and has it affected the ways that you engage with the community and the types of services and programs that have been needed for them?
A really good example is, when we're very, very lucky to have an elder who's been serving at Central Interior Native Health, serving all of us, in addition to our clients, for years now. And when I first came into this position, it was very apparent to me that we were putting a lot on the shoulders of this one elder to be able to do. So we started really leaning on that elder for their guidance and their direction in terms of creating the infrastructure and a governance structure that would continue to honor Indigenous ways, because we're all working in concepts and in structures of colonization. Even though we're trying to move outside of them, these constructs are still colonial in essence and in history, and they persist. A lot of the disciplines that come into work within a healthcare setting are also very colonial and linear in structure. And so there's been a huge need to help to change that narrative, to create paradigm shifts, to create inclusivity within structures and within processes. And I would say that it's been very challenging as a community health center to acquire funding for for Indigenous ancestrally based approaches to health and wellness. It's not been very easy to get funding that would actually help to sustain those positions and then help to create the infrastructure to develop those positions. With the affirmation of the unmarked graves, that really launched from our perspective an opening from provincial and federal government, as well as from private institutions, to provide supports, because there was a lot, and it wasn't just the affirmation of the unmarked graves or the Pope. I would go all the way back to, and it feels like so long ago now, but COVID and the rolling out of vaccinations. That was a big deal for individuals that have survived TB hospitals, for individuals and communities that have survived the government telling them that they know what's best for them, and yet there being devastating effects that continue to impact generations. And so when a vaccine came into being and there was a mandatory aspect to that vaccine, it really triggered the population or the community that we were serving. And so if you were to, when the first kind of call came out for anyone in the community 65 and above, our immediate response was setting aside team members, redeploying them, start making calls to individuals, Indigenous elders, seniors in the community, to say, how does this make you feel? Do you have any questions? How can we help to alleviate some of that burden of making this decision now? But that was really real. And kind of back to what I initially wanted to say was, in having conversations with our elder in-house about the affirmation and kind of the compassion that was, I feel, for the first time more apparent than ever, of the impact of colonization. Her saying and just reflecting on the fact that it was very difficult every time that she drove by a sea of orange shirts in a schoolyard, and that her and her other residential school survivors that she sat with spoke to just the impact and the triggering and the trauma that was coming from the consciousness of everyone else, was happening at the expense of those that have been, living through a trauma that wasn't being properly reconciled and wasn't being properly addressed, acknowledged, accepted, affirmed, all of those things. And so it's been very challenging, and it's been really important for our organization to do things like redeploying team members to provide those supports, also looking for and now finding those funding bodies to continue to create robust infrastructure for Indigenous approaches to trauma. And so being able to help to work through those root issues while addressing social determinants of health, and while helping to aid individuals being able to engage in primary healthcare, but really looking at trauma as being that first point, and now finally being able to recognize that there's infrastructure and there's funding to do it. So being able to uphold that and stress and advocate for that within a community has been something that we've been working really hard on.
That's amazing. I can only relate in the sense of being a racialized woman who had to also live through the murder of George Floyd, and that sense of re-traumatizing yourself as you try to educate and advocate and adapt, and seeing it every day all the time. And it's part of the reason why I really like wrote that question, because I can only feel for that community. And you're the first community health center that I've had the lovely opportunity of interviewing that has such a robust Indigenous population that you serve. And so for me, I have been jarred by this news, and I could only imagine what that community was going through. So thank you for that amazing answer, which made me a little emotional to hear, only because I can slightly relate in a different way. But thank you. And we are going to speak about COVID, of course, in a bit, but I will pivot first to, you mentioned the substance use management programs that you have, and how there's several steps to it, and it's quite extensive from my understanding. Can you explain why each of these elements are necessary in providing effective care for your clients that are accessing these services?
Mm-hmm. So, first off, and we're really trying to pivot to substance use management as opposed to addictions. I think that, it's so important that we address why individuals are in a position in which they're using substances, and how that's a very specific and individual choice, direction, impact of circumstances. Substance use management at Central Integrative Health, first and foremost, starts with the understanding of harm reduction as a philosophy, but also as a strategy. Abstinence is never a conversation that we have or need to have, because we have to create inroads for supports and understand that there's great complexity in substance use management, and just approaching it in that way has been very important. We have for a long time now been providing opioid agonist therapy, and that has been an opportunity for us to train other providers in the community as well on opioid agonist therapy, as well as engaging student learners about the impact that OAT can have on individuals. But part of our opioid agonist therapy is also, again, identifying root causes, traumas, and giving clients an opportunity to approach their substance use management from a non-prescribed way as well. So encouraging and really utilizing our psychosocial team members to connect in with those clients. So mental health clinicians, wellness counselors, and then also what we're really excited about developing as these funding streams have become available is, in addition to sitting down with elders, knowledge holders, and being part of ceremony and connecting back to identity and self, and hopefully being able to work through trauma in that way, is also providing land-based approaches to working through trauma. So there's many things that we're trying to do, understanding that it's very complex and it's going to be very specific to the needs of that individual. Something else that we've been doing, and right off kind of the hop as we were permitted to, was providing providers that were comfortable providing safer supply prescriptions, so that we can help those that are in the midst of trauma, and not even being able to have or being able to facilitate a gap in what they're having to do to continue with their substance use, and then not having a break to maybe reevaluate or pivot or be able to do some of the work that they need to do so they can make some changes that they identify as the changes that they want to make. So we're doing various things, and just understanding that it's very complex, and at the same time teaching and advocating so that there's more access, and there's continuity of care in different areas around the areas that we serve.
Wonderful. So as we briefly discussed before, for the past 2 years, we've been riding the COVID-19 roller coaster. I would love it if you could, in more in depth, explain to our listeners what the experience of the pandemic was like and has been like for the clients and communities that you serve, and also for your community health center in trying to best meet the various needs of these clients.
Mm-hmm. Oh my goodness. I think the first word that I would use to describe kind of my time during the pandemic was advocacy. There was just, as COVID hit and we had to pivot services, we were able to lean heavily on our health authority to be able to bring in the processes and the procedures to do whatever it took so we could stay open and sustain our ability to serve. And we were very successful in that, which was fantastic. But right away, it was very clear that the algorithms, the barriers that were put up were really difficult for those that were already stigmatized, already discriminated against, and already felt as though they were othered in different settings where they were accessing care. The fact that we had to lock a door, the fact that we had to screen at the door, the fact that we had masks on, very pathological, all of these pieces were great triggers for the Indigenous clients that we were serving, that we continue to serve then, and that we continue to serve now. And so right away, there was this understanding that we needed to somehow ensure that this COVID approach was cultural and trauma informed as well. And so that was something that we were now not only were we working with the health authority or with the other centers around us, but now we started to help inform their processes too. So for instance, at COVID vaccine sites, not numbering clients as they were numbered in residential schools, but saying a person's name when they needed to be called up, not ensuring that efficiency didn't dehumanize the experience and create additional trauma. That's just one example. Other pieces that we had to contend with were the fact that we are also serving, because we have created an equity-oriented healthcare model. About 70% of those that we support and serve are self-identified as Indigenous, but another 30 are individuals in the community that are precariously housed, living on or close to the street, those that are at risk of or living with HIV, HCV, and sometimes we directly support TB clients. So, as well as youth at risk and moms and babes at risk as well. So this other 30% too, we're very vulnerable, and everyone as a whole. So in terms of the entire panel that we support, there was huge barriers in accessing testing, in being able to access care during that time. And so something that we did automatically was become a low barrier, or the only low barrier testing site here. And there were really kind of very, only certain locations will test. And we pretty much had to move forward and say, well, we will test because we have to. Our clients can't roll up, message and text and sit in their car if they don't have those privileges. And so we and maintained being a testing site, not just for clients that could walk off on the street. So people that were not our clients as well were able to come in and test, as well as other community service organizations, so they could stay operational, were coming in to test at our site. Another piece was advocating for clients who were precariously housed or were living in situations in which they weren't able to isolate, was being able to work with the health authority, work with BC Housing, work with other local community service organizations, so that we can connect those that we were serving in testing to isolation spaces when necessary. So was a lot of pieces around the advocacy. And the other piece was access to even vaccine, being a community health center, not directly part of the health authority, but being able to access vaccines for our team members who were serving those that were sometimes coming in an altered state of mind, and you wouldn't know they had symptoms until they were sitting in front of you. So being able to bring in the vaccine for our team, but then also for clients as well, being able to realize that we were a space that clients trusted more than a large center deploying vaccine. So being able to bring in vaccine immunization of COVID here in house, so we could do that for our clients and give them the space to ask questions, say no, walk away, but be able to do it in a good way. So a lot of advocacy during that time.
That's wonderful. A lot of work, and I've heard some recurring themes over the episodes, especially a lot around the people who were precariously housed and advocating for them in this a lack of understanding from, I think, more privileged groups that there was no place to isolate for those people. And so I've heard a lot of great work across our whole country, and I'm so thrilled that I get to have these conversations. And that's a lot of daunting but amazing work that you guys have done, and unfortunately continuing to do, and for who knows how much longer, but I can only hope it'll end soon. Do you see any particular gaps in services and supports for members of the Indigenous communities in the region that you serve? And do you have any thoughts on how provincial and federal government policy changes or funding could help you address those gaps?
Mm-hmm. There are huge gaps. Just this morning, our interdisciplinary team sat in circle and we were talking about just the opioid crisis. So, we always say that we've been in a tri-pandemic. So COVID, the opioid crisis, which is going on for multiple years now, and then the affirmation of unmarked graves and the impact that's had on Indigenous communities, and the gaps it's really revealed. So the gaps of working through trauma and not having to get to a place in which we're I'll back up for a second just to say that in our conversations around the opioid crisis, more and more research has been coming out that's revealed that pain is one of the major issues for individuals seeking supports to use, and often not having access to OAT or OPS or and then going and looking for whatever is available. And if that's street drugs, and that's street drugs. And so it's been really interesting to look at pain and pain being physical pain, but also emotional and mental pain as well. And so there's this huge need to look at trauma. And it's not always done so much in our communities. I know that Central Interior Native Health is very unique in that we have an interdisciplinary team and have right away identified that was a huge gap, and we need to be able to have wellness counselors, support social workers to be able to connect with clients and help them where they're at. And so I think this just continues to exacerbate that huge gap. There's not enough social workers, mental health clinicians, wellness counselors to do that important work in talking about trauma and working through trauma. And on the same hand is the traditional approaches to that, the Indigenous ancestral approaches to that, are going to suit the needs of those that remember some of those practices, are more comfortable with those practices, and they're just different in nature. And so sometimes they could be happening in a very organic way, and as a result, it builds a trust of those that are being served. And so we really need to see that where these band-aid solutions, these quick fix solutions, are not necessarily addressing the root causes, the root trauma. And so the ability to expand those psychosocial supports, but also those Indigenous supports, are going to be huge in terms of actually creating sustainable change. And even for our clinic, we want to move out of working with clients in crisis, but actually help to create some sustainable change that they identify as what they want and need to move forward in a good way.
Absolutely. Second last question. What do you think your experience working at Central Interior Native Health Society says about the ability of community health centers to adapt to emerging social and public health issues, and the importance of community health centers within our health and social service systems, especially community health centers that are by and for Indigenous communities?
Mhm. Okay, there's a lot in there. And um, we're agile, like our governance structures enable us to be agile and to meet the needs of clients where they're at without bureaucracy, politics, which sometimes puts us in positions in which we have to be strong advocates. And maybe sometimes that puts us in a good position in the community, or maybe it puts us in a position in which we have a lot of naysayers as well. But regardless, we're able to pivot and provide for the needs that the clients are identifying. I know Central Interior ourselves, client engagement is super key to identifying the services that are available. We need that input and that feedback. And I don't know how, it's harder for a health authority to pivot in that way. But in our case, we've been very lucky to have a health authority that knows that we can provide a niche in a community for community members that cannot be served in the same way in where they're at. And as a result, community health centers have that ability and need to continue to be empowered to provide that really specific work that has to be done to meet our most vulnerable, our most marginalized community members. Because if we can't do that, then we're isolating and we're creating greater problems. And so I think that sometimes we have to be in a position in which sometimes we have a lot of naysayers around us as well, individuals that don't understand what the opioid crisis is, and again, not understanding the impact of colonization. As a result, the fall through of that continues on for generations. And so we have a huge responsibility, I think, as community health centers to be those educators, in addition to doing the work that we do, so that we can hopefully help to spread, illuminate, evolve new processes and levels of consciousness that don't currently exist in a lot of systems that are very colonial in nature and will take time to change.
Thank you so much, Shobha, for taking the time to speak with me today. Before we completely wrap up, I will just ask, my last question is, as always, just if anyone wanted to learn more about Central Interior Native Health, where would they go and what website would they go to find out more about the amazing work that you guys are doing?
Thank you, Hillary. Well, we love to have guests. I think it's really important for us that our equity-oriented healthcare model is something that we hope other spaces and places can absorb and use. I think we do best when we learn from one another. So please come and visit us. I can be contacted. My email will be on our website, which is www.cihs.org. And please check out our website as well for updates. It definitely needs to be updated. But please consider coming out and seeing what we're doing. We have students that work through Central Interior. It's one of our models of the work that we do, so that we can ensure that cultural trauma and violence informed care is something that is practiced in other locations as well. So we definitely would love to have you as a student or just as a visitor coming through.
Perfect. I hope other people visit, but I certainly on my list. First of all, I've never even been to British Columbia, so British Columbia on the list, but I would love to definitely make a stop and get to meet you in person and learn more hands-on the amazing work that you're doing and see it all in person. Thank you again so much, Shobha, for taking the time to speak with me today.
Thank you so much, Hillary. It was a pleasure.
Thank you for listening to Community Matters, a podcast from the Canadian Association of Community Health Centres. To learn more about our association and the important work of community health centres across Canada, go to www.cachc.ca.